Good morning, everybody. All right, so in 20 minutes or 25 minutes, I'm going to deal with all these issues, the adjuvant and neoadjuvant use of anti-HER2 therapy, combining trastuzumab with other therapies, second-generation choices, and then novel agents and conjugates. So we'll roll through this. It's a hard slide to see. It just talks about the potential mechanisms of action of trastuzumab. And really, there are multiple things that trastuzumab does, and I still think we're not sure which are the most significant of all the effects, but we do know that it does interact with the immune system, and that it may be that immunity predominantly with ADCC is the predominant function, but there are multiple mechanisms of action of trastuzumab. So let's talk about frontline therapy for metastatic breast cancer. We all know about the pivotal trial that was published by Slayman, which was patients who had not had AC were put on AC with or without trastuzumab, and those who had had adjuvant AC got paclitaxel with or without trastuzumab. There's not been an update on this data, but the response rate, time to progression, and survival were clearly superior by adding trastuzumab, and this changed very rapidly all of our standards of care for patients with HER2-positive breast cancer. NCCN, up until about a year ago, had this as their recommendations for frontline therapy for patients with metastatic breast cancer who had not had previous trastuzumab. Their recommendations was trastuzumab with paclitaxel with or without carboplatin, docetaxel or navalbine or capecitabine. So that was sort of the laundry list of what was recommended by NCCN as your frontline therapy if you'd not had prior trastuzumab. And there are 18 trials here of triplets that have been done. None have been all that informative, but you should just be aware that multiple drugs have been looked at as a doublet with trastuzumab, and none of these are meant to be compared to one another because they are all phase 2 type trials with about 40, 50 some patients within them, so that you can add a platinum type compound to either a taxane or to an anthracycline, predominantly Doxil that was given here, but I don't think any of these has turned out to be such a home run that we are now using a doublet with trastuzumab in a standard way in the metastatic setting. And then there are the older trials that looked at combining hormone therapies. So the top trial there of the trastuzumab alone was Chuck Vogel's look at just single agent trastuzumab with a response rate in the front line of 26%. And then there was the small randomized trials of anastrozole with or without trastuzumab. I think what was most instructive to me from that trial was how bad the response rate was in progression-free survival in patients who are HER2 positive receiving an aromatase inhibitor alone. And then the lapatinib letrozole versus letrozole trial, same sort of really not encouraging progression-free survival with the hormone therapy alone. And there are data using lapatinib alone in the front line as well. So we're all very aware of the potential mechanisms of action of trastuzumab. We know that lapatinib, which is a tyrosine kinase inhibitor, works intracellularly. It is binding both HER1 and HER2 and then blocking downstream signaling. The frontline trial, I think people are probably a little less familiar with this. The frontline trial of lapatinib had 138 patients. They were randomized to one of two arms of lapatinib in the frontline. Again, these are patients who had not had trastuzumab. And the response rate actually wasn't that bad. It looks like response rate of single-agent trastuzumab in patients not previously treated. It's in the mid-20%, clinical benefit rate about 30%. And progression-free survival, 6-month progression-free survival in about 40% of patients. So as a single agent, there are data. It's not that bad. And then we have the issue of how about in the front line, are there any signals that there's a benefit of trastuzumab versus lapatinib? This is a trial that Karen Gelman presented at ASCO this year, asking that question. It's the first time this question's really been appropriately asked. And this is a trial of about 600 patients. Turns out only 536 of them were actually HER2 amplified. And so patients got some taxane, either paclitaxel or docetaxel, for 6 months. So it was 24 weeks. And then they got either trastuzumab or lapatinib as their anti-HER2 agent. And then they only got the chemotherapy for 24 weeks. They came off the chemotherapy on both arms and then just continued on their anti-HER2 blockade. And it is clear from this trial that lapatinib in the Frontline is clearly inferior to trastuzumab as the anti-HER2 agent when you're combining it with a taxane. So I think that in the Frontline setting, at least, I don't think it's appropriate that using lapatinib as the anti-HER2 therapy. All right, so then the question is, how about beyond Frontline? Because most of our patients, at least in the adjuvant setting, are now seeing trastuzumab, and we're tending to use trastuzumab in the Frontline setting and the metastatic setting. So then what should be done in the second-line setting? And again, NCCN up till 2012 said, okay, make sure that you continue HER2 blockade. You can use any chemotherapy essentially with trastuzumab in your second line. You could use capecitabine with lapatinib. We all know that trial, review it very rapidly. Or you could go to trastuzumab lapatinib, just do an all anti-HER2 therapy and drop the chemotherapy. So this is the trial that got lapatinib approved in the second-line metastatic setting. This was Chuck Geyer's presentation in the New England Journal of Medicine in 2006. And these were patients with metastatic disease, HER2 positive, who could have had unlimited prior therapy but had to have had trastuzumab. And they were randomized to capecitabine or lapatinib capecitabine. And that showed that with patients with one prior trastuzumab regimen, a clear advantage of the lapatinib added to capecitabine over capecitabine alone. When you start to get patients heavily pretreated with multiple trastuzumab regimens, the lapatinib arm, although it was improved, didn't seem to be as impressive. But in fact, there is a significant improvement in response rate. There's an improvement in survival, which was not statistically significant, but time to progression was significantly improved. And then there was this tinkling question about the brain met issue because they saw less brain mets as the first site of progression for those patients who were getting the lapatinib versus the capecitabine. Then the question came up, how about the combination of lapatinib, trastuzumab? There's plenty of animal data around this supporting that combination. They clearly appear to be synergistic, both in vitro and in vivo. And so the pivotal trial, as presented by Kim Blackwell and published in JCO last year, looked at patients who, with metastatic breast cancer, who had had multiple lines of trastuzumab and progressed on trastuzumab at the time of study entry. The patients were then randomized to lapatinib as a single agent at 1,500 milligrams a day, or the combination of lapatinib at 1 gram a day, and then the standard dosing of trastuzumab. The patients who were on the lapatinib arm, when they progressed, were allowed to cross over to the doublet. And that trial showed a doubling of progression, 6-month progression-free survival if you just started with the combination together, even though patients had had a median of 4 prior trastuzumab regimens. But progression-free survival was 2 months versus 3 months. I mean, it's a lovely combination, and I've used it multiple times, but I still kind of tend to want a chemotherapy on board for the majority of my patients. And these are the overall survival data that were presented, showing a survival advantage of the doublet versus single lapatinib for these patients. And then this is the trial that was presented by von Minkwitz that looked at, in the second line for patients who were failing trastuzumab, switching them from capecitabine or trastuzumab to capecitabine. There's a lot of problems with this trial. It did not complete its planned accrual because lapatinib capecitabine got approved in Europe, and then they started to have accrual problems on this trial. But for the patients who did end up on the trial, there was an improvement in progression-free survival with the combination of capecitabine plus trastuzumab versus capecitabine alone in the second line or third line setting. So I think that it's unusual. I would think that anyone would drop your anti-HER2 therapy no matter what your line of therapy was. So let's go back to Frontline again and the introduction of pertuzumab. So with regards to the mechanism of action, there are actually 4 domains on the HER2 transmembrane protein. Trastuzumab binds to subdomain 4, and it inhibits HER2 signaling. It activates ADCC and prevents HER2 extracellular domain shedding. Pertuzumab actually links to a separate subdomain of the transmembrane protein, and predominantly it's blocking dimerization with HER1, 3, or 4, although HER2, HER3 is the strongest bind and creates the most signaling. So it's the blocking of this dimerization, which is probably the most important issue here, but also activates ADCC. There are trials using pertuzumab as a single agent. It's modestly effective, not clearly as effective as trastuzumab is. So there's something about this doublet seems to be much more significant than considering pertuzumab alone. This is the phase 2 trial of just the combination of pertuzumab and trastuzumab together without chemotherapy, with about 50% of patients at least having a clinical benefit rate, with a median duration of response of the combination being almost 6 months. This led to the Cleopatra trial that was published last year in the New England Journal of Medicine. This was a randomization. Everybody got docetaxel as their chemotherapy regimen. This was really a European-driven clinical trial. Everybody got trastuzumab in the standard dosing, and then patients were randomized to placebo or pertuzumab. These are patients with HER2 positive metastatic breast cancer, and they were allowed to have adjuvant or neoadjuvant trastuzumab, but they had to have at least a 12-month interval where they had not seen trastuzumab for this trial. The results are a 6-month improvement in progression-free survival with the addition of pertuzumab in the front line. And survival, as presented and updated by Sandy Swain at the San Antonio meetings in December, showed that there's a clear survival advantage now with the addition of pertuzumab in the front line. So what are the additional toxicities from pertuzumab? There's a little bit of an increase in febrile neutropenia. We saw that when we added trastuzumab to chemotherapy. We're seeing it now when you add pertuzumab on top of trastuzumab in chemotherapy. Otherwise, very little hints about additional toxicity other than cost. And if anything, there was a halving of the cardiac toxicity that's seen with trastuzumab. That is not understood why there would be cardiac protection. It was not statistically significant, but there was no hint that there was an increase in cardiac problems. So NCCN then in 2013 has changed their guidelines, saying that frontline therapy with no prior trastuzumab exposure, that your preferred regimen is a regimen that includes trastuzumab, pertuzumab, and either docetaxel or paclitaxel, even though there are no trials asking the paclitaxel question that have been completed and presented. NCCN, in recognition that many U.S. oncologists prefer to use paclitaxel as their taxane of choice. So they have given that as the option for frontline as the preferred regimen, and then you could, as a second option, use any other chemotherapy regimen with trastuzumab in the front line, no longer defining what the chemotherapy is. And then with TDM1, very, very interesting compound, and I think it's just the foray into multiple new compounds that may be coming down the line with this linker technology. As you know, this is trastuzumab. So I'll say this right now, you don't want to ever give TDM1 and trastuzumab together. They will compete with one another. So they've done the packaging so that you don't get confused, that the pharmacist doesn't get confused, the dose is funny so that you don't get confused. So this is trastuzumab, the chemotherapy drug, emtansine, and a linker that links the maytansine to the Herceptin. The average of a drug to antibody ratio is about 3.5 to 1. And the Amelia trial, which has been also published in the New England Journal of Medicine in 2012, looked at patients with metastatic breast cancer who had had prior taxane and trastuzumab. So everybody's gotten trastuzumab here. So this really is second line or beyond. And the patients were randomly assigned to the standard dosing of capecitabine and lapatinib, like it was FDA approved, versus TDM1. The TDM1 dosing is 3.6 milligrams per kilogram. Again, they wanted to not look like trastuzumab. They didn't want it to be 2 milligrams per kilogram or 6 milligrams per kilogram so that we don't get confused about that. The primary endpoint of the Amelia trial was progression-free survival. There was a 3-month progression-free survival that was seen in this trial favoring the TDM1. And in the New England Journal publication, there was a survival advantage, which is almost a 6-month survival advantage by giving TDM1 in this second-line setting versus capecitabine lapatinib. What are the toxicities? So on this slide, it's hard to see it. I've highlighted on the left the predominant different toxicity of TDM1, and it really is thrombocytopenia. They saw 28% all-grade thrombocytopenia. Most of it tends to be very mild, and it will have resolved by the next cycle. So TDM1 is an every 3 weekly regimen. And so if on the trial, they did weekly CBC, so they did see some grade 3 thrombocytopenia, but very, very few episodes of bleeding and even more rare requirements for platelet transfusions. The other thing that you got to watch for is a transaminitis, and I think those are the two big things you need to watch for patients on TDM1. Everything else was really a very minor toxicity, and then capecitabine with the diarrhea and hand-foot syndrome along with lapatinib, we know are those predominant toxicities. TDM1 really, I think, one of the better tolerated because most of our tissues are protected from the chemotherapy regimen here because the linker is unlinking intracellularly and very few cells that are HER2 normal are actually seeing this drug. So just in summary for the TDM1, it showed improved efficacy versus capecitabine lapatinib. I've had no trouble getting this drug for my patients at this point. All right, so how about other trials for metastatic breast cancer? What else can we expect? Well, the Marianne trial is a phase 3 trial, and this trial is in patients frontline, not treated with metastatic breast cancer, and they will be randomized to what could be considered to be a standard, which is trastuzumab taxane, versus TDM1 plus pertuzumab, versus TDM1 plus placebo. So now we'll start to see if there's a benefit of the doublet of pertuzumab with TDM1 from this trial, and then be able to compare in the front line TDM1 with trastuzumab plus taxane. Is there an advantage of this linker technology other than a reduction in toxicity? And then the issue of mTOR. So Tom introduced the whole issue of PI3 kinase AKT pathway. This is also thought to be a pathway upregulated in patients who are becoming resistant to trastuzumab. And the question is, can you overcome trastuzumab resistance by blocking mTOR? And that is the Bolero-1 trial. So the Bolero-2 trial is the one that he presented using hormone therapy with mTOR. This is the Bolero-1 trial, not yet reported, and that is a trial of trastuzumab paclitaxel versus trastuzumab paclitaxel and everolimus. And we are waiting for presentation of this data, and we're hoping that it'll be presented sometime this year. All right, so in the metastatic setting, we have multiple options. In the frontline setting, I think we are now seeing a survival advantage with pertuzumab. And in the second line setting, I think we've got TDM1 that will at some point probably be used for our patients. All right, so how about early HER2 positive breast cancer? We'll talk about neoadjuvant first. There are a whole bucket list of neoadjuvant therapies asking similar questions of what is the best combination of anti-HER2 therapy. This is the Gepard-Quinto trial. This was epirubicin cyclophosphamide followed by docetaxel and then surgery. And the randomized arm was lapatinib versus trastuzumab. And this shows clearly that the trastuzumab in the neoadjuvant setting is better, and now we have also seen that in the metastatic setting as well in the front line. The Neo-ALTO trial is asking the question of paclitaxel as its base chemotherapy, and then the randomization is with lapatinib versus trastuzumab versus the combination of lapatinib and trastuzumab in the neoadjuvant setting. If we're just looking at the PCR rate, you can see that the chemotherapy with the doublet almost doubles the PCR rate for those patients in a neoadjuvant setting. The question, again, will be, will this translate into the adjuvant setting? And what is now an ongoing theme on all of the neoadjuvant trials are that if the tumor is hormone receptor positive, even though they're HER2 positive, you will not see as high a pathologic complete response rate as you will if they're ER negative and HER2 positive. So we're for a long time we're thinking, wow, great PCR rates for these patients that are HER2 positive, but there's a clear difference. If you're ER positive, you should not expect such a high pathologic complete response rate, although clearly 41% is better than a HER2 negative ER positive, where you could expect PCRs to be under 10% if you're going to use chemotherapy. The Neosphere trial by Luca Gianni, again, now we're adding pertuzumab as the question, not lapatinib. So this is a 4-arm neoadjuvant trial. Docetaxel is their chemotherapy. So it's docetaxel, trastuzumab, docetaxel, trastuzumab, pertuzumab, or forget the chemotherapy, just trastuzumab and pertuzumab, or docetaxel, pertuzumab. So it's a color coding here. And the best arm was the docetaxel, trastuzumab, pertuzumab, very similar to what was seen in the Cleopatra trial in the metastatic setting. And I think that gave them hints also for the Cleopatra trial that this combination might be really an extraordinary combination. Again, if you look at the issue of hormone receptor positive versus negative in the HER2 positive setting, pathologic complete response are much, much less if you're ER positive, and that was again seen in the Neosphere trial. So that the blues here are the ER negative and HER2 positive, and the yellow is the ER positive, HER2 positive. So I don't think you should not offer chemotherapy in the neoadjuvant setting here with trastuzumab, but you should not expect these 40, 50, 60% pathologic complete response rates if they're ER positive. And then NSABP B41 presented at ASCO this year. This is AC followed by weekly Taxol with either trastuzumab versus lapatinib versus the combination, and it showed that the pathologic complete response rate of the combination went from about 47, 48% to about 60%. So lots of evidence in the neoadjuvant setting that the combination's better. We now know in the metastatic setting the combination's better as long as you're using pertuzumab. All right, and so in the adjuvant setting, we all know about the adjuvant trials. They were updated within the last 2 years for their data. This is 9831 AC followed by Taxol with concurrent or sequential trastuzumab, and then the NSABP trial, which was AC with every 3-week paclitaxel with or without trastuzumab. Those data have been combined for the joint analysis, and the joint analysis has now been updated in 2011 JCO, and it continues to show an improvement in event-free survival, and that over time that these curves actually continue to widen, showing the advantage of having been randomized onto a trastuzumab arm. Then they looked at, on a forest plot, multiple subgroups. There were very few patients in these 2 trials that were lymph node positive. And so it's not very informative, but every other group, there was a benefit of using trastuzumab. What I think is instructive is the events and when they occur, and you can see that within the first 3 years, you are seeing the majority of recurrences on both arms, both the trastuzumab and non-trastuzumab arm, but that there's always an advantage for those patients who receive trastuzumab. And then the controversial issue of a non-anthracycline regimen. the AC followed by docetaxel with or without trastuzumab or versus TCH. This was updated in 2011 by Dennis Slayman. And I'm just showing this slide to show you that almost 30% of the patients in this trial were lymph node negative. And here are their updated curves for disease-free survival. So the problem with this trial is their two Herceptin arms are not meant to be compared to one another. The trial was set up as AC followed by docetaxel with Herceptin or TCH, and both compared to the non-Herceptin arms. They were not meant to be compared to one another, except that we do. So it appears that TCH may not be doing as well here as the AC followed by docetaxel. And it always runs a couple percentage difference by a couple percent by progression-free survival and overall survival, a 1% difference between the two, suggesting that TCH isn't quite up to snuff. If you look at the different lymph node groupings, the lymph node negative patients, there was about a 3% difference of AC followed by TH versus TCH, although again, they're not meant to be compared to one another. And so you go, okay, for my really bad patients, maybe they need anthracyclines. But if you look at the 4 or more positive lymph node group from that trial, there's no difference in the two arms. It's 73 versus 72% disease-free survival. So I think people have decided whether they want to use an anthracycline or not. This very august group of breast oncologists through this country decided they needed in June of 2012 to inform us of which of these is the correct thing to do. So you have your whole list of people who are going to weigh in on this. I didn't see the Dennis Slayman editorial against it, but these authors suggest TCH should not be a preferred regimen, that BCIRG 06 was not powered to show equivalence or non-inferiority, that numerically there are fewer recurrences and deaths in the ACTH arm than TCH. And the authors of this article encourage all of us to use an anthracycline-based adjuvant trastuzumab regimen and only use TCH if there's some contraindication. And I can only tell you TCH is my regimen of choice. Finally, there are the two trastuzumab regimens that were compared. There's the HERA trial at ESMO this year. They updated the 2-year versus 1 year. So you know this was everybody's done with their chemotherapy. Then they're randomized to observation 1 year of trastuzumab or 2 years of trastuzumab. The trastuzumab was not given concurrent with chemotherapy. And this is looking at the disease-free survival curves. So if you look really early in here, you could see that there's suggestion that there was a difference, that 2 years was going to be better than 1 year, but subsequent with longer follow-up, that fell apart, and there's no advantage of 2 years of trastuzumab over 1 year. These are the overall survival curves. There's just no hints here now at 8 years of follow-up. So I think we're going past 1 year in the adjuvant setting. And what was surprising to me is that past 1 year, you continued to see cardiac problems in that second year of using adjuvant trastuzumab. So I think that there's just no advantage here. That was countered by the FAIR trial, which was looking at 6 versus 12 months of trastuzumab. Could we cut it out earlier and not give it for the full year? This is set up as a non-inferiority trial. So clearly 6 months of trastuzumab is not going to be better than 12 months of trastuzumab. So it's set up as a non-inferiority trial. It's a little complicated with regards to the statistics here, but there are 3,400 patients in this trial, and not that many disease-free survival events. Numerically, there are less in the 12-month arm versus the 6-month arm, and this just is where the disease-free survival events have occurred. The problem with this is inferior is the bottom group here. So if it were inferior statistically, it has to be 1.3 hazard ratio or higher. If it's equivalent, this is 1. So no difference between 6 months versus 1 year. The FAIR trial sits here. So it's heading towards 6 months being inferior, but it's not statistically significant because it crosses this 1.15 statistical arm. So If you look at the subgroups from this trial, it's a very large trial. About a quarter of them were estrogen receptor negative, and these are really the patients that it is inferior to use 6 months of trastuzumab. The other patients, it's certainly trended to be inferior, but not statistically significant. And then on the bottom, you can see all patients from this. So it failed to show that 6 months is not inferior, but I think there's certainly suggestions that 6 months could be somewhat inferior, especially if they're ER negative. And there are 3 other trials that are asking the same question that we're waiting the data upon. And just finally, pending clinical trials, TCH with or without bevacizumab, the BETH trial is pending. The ALTO trial is a pending presentation. That's paclitaxel in all arms given weekly after AC. And it's paclitaxel with trastuzumab, trastuzumab followed by lapatinib, this arm got closed because of inferiority, or the combination of trastuzumab plus lapatinib. So we'll have this question in the adjuvant setting. And the affinity trial is asking the pertuzumab question. So whatever your chemotherapy is of choice in the adjuvant setting, add it to trastuzumab, and it's with or without pertuzumab. So my conclusion is that trastuzumab, in addition to chemotherapy, remains the standard for all high-risk HER2 positive early breast cancers. The controversies that exist are the use of anthracyclines or not, what high risk means, the role of additional biologic agents in the adjuvant setting, and the optimal duration of trastuzumab for patients as well. And here are my final thoughts. But I think we've got pertuzumab and TDM1 that we're trying to figure out how to put into the mix right now. Thank you very much.